akutkirurgi, det bedste, man kan beskæftige sig med inden for kirurgien. Vi har lagt et hårdt program her, og vi håber, at vi kan bringe lidt enlightenment til jer inden for nogle af de allermest akutte patienter, nemlig ileus-patienterne.
I want to welcome our first speaker. That's you, Matt. Ismail this morning did an excellent introduction that I couldn't do any better. I would say it's so nice to have a colorectal surgeon sharing our passion for small bowel obstruction and building a bridge between the elective and the emergency surgery departments. Yeah, Matt, take it away.
Okay, lovely. Thank you very much. I apologise that it's in English and not in Danish, and I do appreciate the effort you've made to involve me with this. So I'm very pleased to be here to talk to you all today about the National Audit of Small Bowel Obstruction, which was a UK-wide initiative in 2017. I was one of the 2 trainee leads on this, and it was supported by, you can see there's lots of badges, lots of logos. Every one of those organisations bought into this. So the general surgery and emergency surgery groups, all the colorectal and upper GI groups, even the gastroenterologists and the nutritionists got excited about this project. And I'll talk you through and tell you a little bit about why they were interested. I've put the website at the bottom. You can find a report and a little bit of protocol data on there if you're that excited. And you can see our Twitter handle, which you may want to follow if you want to find out more about what's coming. So why are we interested in small bowel obstruction? If we start with emergency surgery, I think everyone's aware that emergency surgery accounts for a massive part of our clinical workload. We are dealing with more and more complex patients. They're getting older, they have more and more comorbidities. And their expectations have changed, whereas 10, 15 years ago, we might have looked at someone and said, maybe we shouldn't be doing an operation for you. Now we're saying, let's try and do everything we can to get you through this acute episode and help you get decent quality of life afterwards. You do not have to look very far to find a report. Certainly in the UK, we have lots of reports published that tell us we're not doing very well at emergency surgery, particularly. This is last year's NELA report. The new one has just been published today and says that we're doing better, but there's room for improvement. And why we're interested in small bowel obstruction specifically, if you look at the NELA data, which is the National Emergency Laparotomy data, half of all emergency laparotomies in England and Wales are done each year for bowel obstruction. So if you want to look at emergency laparotomy, you have to deal with small bowel obstruction. But beyond that, we all know that not everyone with bowel obstruction gets operated on. So whilst it accounts for half of our operated cases, it accounts for a significant proportion of our non-operated or conservatively managed cases. So we thought this was a great area to look at to really dig down into why we're having some problems with our outcomes. This is a very simplified diagram, and it's a little bit wrong. It's just one version of truth, which we'll accept. So this is why we've looked at it. So small bowel obstruction, easy, isn't it? If a patient comes in, they're obstructed, they've not had a laparotomy before, they've not had surgery, they're probably going to get an operation. Done. If they have had surgery before, or it might be a recurrent cancer, you're going to think about it, do some tests, maybe try and get out of things without doing an operation, and then eventually commit to doing an operation when they don't get better 3 or 4 days down the line. A little bit cynical. This is 3 years of presentation. What happens then? So we've got these patients. They might start resolving without an operation. So they start, stop being sick. They start passing flatus. Great. We can start feeding them again. But the ones who we operate on, they've got another 3 or 4 days of ileus down the line. So they've been obstructed for 2 or 3 days. Now they've got 3 or 4 days of ileus to get through. So we're starving them for a long time. And this project came about because a colleague and I were sat in a sort of a small district general hospital looking at some of our patients who had been put on conservative management for 7 or 8 days, or inactive management, non-management, for 7 or 8 days without anything really being done. And we were trying to figure out when we could actually convince people to press the button on things like parenteral nutrition, when we could really force them into doing an operation. And that's why this came about. We've delivered this project was only possible because of the trainee research groups we have in the UK. So each of the geographic regions of the UK, which is based on the training programs, has a group of trainees who do research, general surgery research, typically, although there's specialist groups. And these are groups that can pull together a large amount of data in a small space of time. So if you want to know what's going on right now, we can get a study done, give you a month's worth of data, and it will tell you all of that. And it does it with high levels of validity, sort of in excess of 90 to 95% data accuracy. These groups, what usually happens is groups run a little regional project where they'll get 10 hospitals and it'll give you a hypothesis that needs testing with a trial, which some groups go on to do. But once a year, we try and have a big national project where every group says, yes, this is the thing that we're going to work on this year. And this is what we convince people to work on. So this project was supported by each one of the trainee research groups across the country. We had as we were putting this project together, the Coloproctology Association and the Royal College of Surgeons said they wanted to look at bowel obstruction. So we all agreed to work together rather than doing the same study 3 times and wasting resources. And everyone else came on board, and we convinced them, we got some charity funding, and then convinced everyone else that if they thought it was so important, they should give us a little bit of money to do the project as well, which was very helpful. This project took place over 8 weeks between January and March 2017. We asked participating centres to identify anyone who came into their unit with a clinical diagnosis of bowel obstruction of any etiology, with the exception of people who had left-sided colonic tumours, because the obstructed, if you've got large bowel obstruction, that's a different treatment paradigm, and there's so few of them that would muddy the water. And they had to be adults as well. We asked them to collect data on basic demographics, so thinking about their age, sex, comorbidity, and comorbidity was captured using the Charlson Comorbidity Index, which is a point-based system. It's not brilliant, but it does the job. And we asked them to tell us about management strategies, so did people go straight to surgery? Did people have surgery after a delayed period of time, or did they get better on their own? As well as looking at what diagnostics they had, CTs, X-rays, things like that. And then we looked at their outcomes, things that mattered to us, like death, reoperation, unplanned use of intensive care, which means not from the operating theatre. This means someone who was sick on the ward and had to go to intensive care is an unplanned case. And we undertook a validation exercise. We randomly selected 5% of all cases, and we asked centres to recheck the data on all 5 of those. And the accuracy came in at 93%, which was pretty good, and the inaccuracies were largely down to rounding errors. So we're fairly happy with the data we're going to talk to you about. So in all, we got data on 2,434 patients in 8 weeks. This was captured across 131 hospitals all across the UK, and with the help of about 520 trainees and consultants across the country who bought into the project. I have to tell you about the risk adjustment that we've done, some of the risk adjustment we've done for this, because it won't be immediately apparent. I've told you we've used the Charlson Comorbidity Index. We were also interested in nutrition because this group of patients is in a state of acute gastrointestinal failure. So we needed some way of looking at malnutrition. In the UK, we have something called the MUST score, which is the Malnutrition Universal Screening Tool, and it's expected that everyone admitted to hospital should have some form of malnutrition screening. This is the preferred one in England. And I think it's what's recommended, but I think it's quite a finger in the wind type scenario. So if you can see, there's questions about where they're starting with their BMI, have they lost any weight, are they at risk of not eating for several days? And I would argue that actually the only thing that matters here is acute disease score, because if you've got bowel obstruction, you probably should be ticking a box here, so you should be by definition at risk of malnutrition and going through to having interventions. But, well, as we'll see, that isn't quite what happens. And that doesn't actually say that you have to do anything, it just says you have to ask a dietitian as one of the allied health professionals for some input. So we used this as a secondary adjuster, the Nutrition Risk Index. There's lots of different ways of adjusting. This is one that we went for, which is basically looks at the difference between your actual and ideal body weight and multiplies it by your albumin at admission. And I know albumin is not a marker of nutrition, it's a marker of sepsis, which is usually the argument. We do have data that shows that it's fairly reliable in this setting. And this is just to prove to you that we did manage to get most of the hospitals in the UK on board with this, so this is real world data. We did have some further up in Scotland, but you zoom out much further than this and you get France and other countries starting to creep in. So one of the other ways that we managed to do this, some of you will be, I know that some of you are prolific Twitter users. we found Twitter to be a really good way of doing this. Every week that this was running, we sent out an email to everyone who was registered as a collaborator on this. They got the same email, but we put it out on Twitter as well. And you can see, and we did things like, is that going to be it? We did things like put out a top 10 recruiter list for the week. Because if you want surgeons to do something, you have to make them compete. And what I mean, I don't know how good your UK geography is. It's probably as good as my Danish geography is. So Margate is a very, very small district general hospital in the southeast. And yet, for most of the time, they were leading the field, and I was getting accusations of fixing. And one person emailed and demanded I had drugs tested all the doctors there. In the end, it was the usual suspects. It was places like Leeds, Cambridge, Salford, all the big teaching hospitals who ended up giving the most cases. But it was still good to say every week there's someone different at the top. And we also did this, looking at how much impact we had, how many people we were managing to hit with all our tweets, and we can map the data. We can map the logins on our system to the time these tweets went out. So these were actually pretty good at getting people doing stuff. So if you're thinking about doing something like this, have a look at that. So I've got some data, and it's mostly graphs from here on in. We split, for the purposes of analysis, we've not split in the main by etiology. So we've not said, this is adhesives, this is hernias, whatever. We're trying to group people, because small bowel obstruction is a syndrome. It's a collection of symptoms caused by something. We split them into people who were managed non-operatively, which is over there on the far side, biggest group. People who were managed operatively within the first 24 hours. So this is that sick group who come in and you look at and say, don't like the look of you, you're getting a big cut. And then you've got this delayed group over here, which is typically your adhesives, where you want to wait 2 or 3 days. Well, 2 days, we can argue about timing. Or the people who've got cancers where you may be trying your best not to go into the abdomen because you know it's not going to end well for anyone if you have to go in. What we can see from this, so your red bar is the people who've got adhesive small bowel obstruction. I'm not surprised that that's the biggest group in any way. And what you can tell from this is that it's roughly 50% of people didn't get surgery, 50% of people did get surgery, but the adhesive split is 2/3 and 1/3. So your operations are coming in the other groups. The second most common cause was abdominal wall hernia, which probably doesn't surprise you that much. And typically this is this nice lemon colour, typically an older group. So the average age was 69 years old. This skews over towards the right, maybe 80 years old. And most of them get operated on, which again, is not a massive surprise, and we'll come back to the hernias later. The third biggest group was malignancy, which is this nice green one. And this is quite interesting data, which I'll come to later. But you've got a mix of primary and disseminated disease in there, all of which add to some of the heterogeneity we see. And then we've got this other group. So there's people who had intra-abdominal abscesses due to diverticular disease that had pulled the loop of small bowel in and caused small bowel obstruction. 1% of all cases was gallstone ileus, and it's other sort of odds and ends like that. So this is a survival curve, and we've split people by the three management strategies. So you can see up at the top is the people who were managed with delayed surgery. So that's a group where you've got a couple of days to resuscitate them, or you try not to go in, then you operate on them. The orange group is the people who were operated on straight away. And then down here with this rather naff-looking survival curve is the people who aren't operated on. Which brings us to the first caveat of this data. It's observational. I'm not trying to tell you that not operating on someone kills them. I'm telling you that this data's a little bit skewed because this is a group of people where we're making a decision not to operate, or the patient doesn't want an operation, and that's probably why. So this is all association, not causation. The overall in-hospital mortality rate was 7% for all comers, okay, which matches the NELA data more or less. The next debate, so if you go back to papers from 1948 to 1949, you can find papers that are entitled A Plea to Treat Small Bowel Obstruction Within 24 Hours, or words to that effect. And actually there's one author who wrote 3 papers over 5 years with very similar titles because he was seeing exactly the same problem happening again and again. People were waiting too long, hoping that things would get better, and they didn't. What we've done here is we've stratified patients by their Charlson comorbidity score. 0 is good, that means they have no comorbidities, they are fit and well. 1 to 10 means they are averagely comorbid. And 11 and above means that they are really comorbid. And this is a group that we probably want to be staying away from as surgeons if we can. And there's an interesting pattern that with the eye of faith you can see is there. The lines are set as people over 80 years old, over 70 years old, over 6 and under 70 years old. So young people, bit older, very old, and you can see their risk profile changes. And there's a bit of shading to show you the confidence intervals. And obviously where we've got smaller numbers, the confidence intervals are wider. I think this probably illustrates, the middle chart probably illustrates the thinking best. If you've got someone where you are operating on them really early, it kind of holds true here and definitely here, they don't tend to do very well. But that's because they need an operation right now. They are sick enough to need that operation right there and then. There's probably not that much that we as surgeons can do about that. It's probably everything else we need to deal with. You then get, it's most exaggerated here, but you get this sort of golden period appearing where the risk of mortality drops off. And when we've looked at the data in slightly different visualizations, it's about 2 to 3 days. You get this nice window where the mortality seems to be better. So that's a patient where we recognize they're not getting better. We've done all the optimization we can. We've given them fluids. We've got them sat up doing a bit of chest physio, whatever. They're going to do better. And then you've got the group that people don't want to operate on. And you can see, bang, up goes the risk of mortality. So that's a group where we've missed the boat. We should have done something about it. We didn't do anything about it. And now the patient's going to pay the price. There's a chart which we're not going to show you here, but shows you the rates of small bowel resection according to time of surgery. And it does something a bit like this. So if you operate within the first 24 hours, your patient's got about a 1 in 4 chance of having to have a small bowel resection because they're sick enough they need a small bowel resection. You operate here, they're well enough, it's just time that's triggered you to operate. You're probably going to get away with whatever, adhesiolisis, whatever. And then as you wait, the rates of small bowel resection climb again. And that's because you're operating now because the patient's sick, because they've gone toxic, they've got an ischemic loop of bowel. And I think that's what we're seeing here. If you look at the NELA data, which looks again at all causes of small bowel obstruction, they reckon that mortality shoots off at 72 hours. So if you're waiting beyond 72 hours to treat someone with small bowel obstruction, they reckon you've missed the boat. These are the other outcomes that are really interesting, or should be interesting to us as surgeons. We have acute kidney injury was present in 1 in 5 of the patients when they were admitted to hospital. We didn't look at repeated measures of renal function because it would have been too much of a burden on the data collectors. That's single. So you actually got someone who's got small bowel obstruction. So that's gastrointestinal failure, 1 organ failure. They now have acute kidney injury, 2 organ failure. So their mortality is just starting to incrementally climb. So this is something we need to be aggressive on. Cardiac complications, which includes myocardial infarction, arrhythmias, things like that, 6% of patients. 12% of patients got a hospital-acquired pneumonia, which is quite a lot of them, and you imagine that adds 2 to 3 days to their hospital stay. 1 in 10 patients had an unplanned trip to intensive care or high dependency. That is not from theatre, that is people who are being managed on the ward, who deteriorate, who end up there without going through an operating theatre. 5% of people had delirium. We put delirium in because it was quite topical last year. There's a big focus on the care of the older surgical patient. This is one of the big things that came out of this. And 5% of patients had a second operation. And it's really interesting when you look at why they're getting reoperated. The abdominal wall dehiscence rate was 3% overall. So most of that is accounted for by people who needed their abdomen closed because it primarily dehisced. The other people were quite often adhesives where the correct adhesions hadn't been divided, so they'd had an incomplete adhesiolysis, so an incomplete treatment, and had to go back for their final laparotomy. Again, it lengthens your care, your hospital stay. Now, having said, I cannot talk about causation. I can only talk about correlation, association. I'm going to commit a sin here. Kidney injury. According to how you treat people. Kidney injury doesn't seem to matter that much if you have an operation. But in the people that we're not operating on, having kidney injury at baseline seems to be associated with worse outcome. Now, why is that? Is that because we're fixing the underlying problem here, which is your third space losses, your inability to absorb, is that what's being fixed here? Or is it that we're, A, not fixing it, and B, maybe neglecting these patients because they're non-operative patients? It's not really surgical patients, they're just on our ward and we're just waiting for them to get better. Is that what's happening? And the next two slides I'm going to simplify because these baffled me when they first came out. We've done some modelling looking at factors associated with in-hospital mortality and then one on major complications, which I'll talk about. So this is what the factors associated with mortality. I find it easier to split this down into things that we can't change and things that we can change. So if we talk about things that we can't change how old someone is, and unsurprisingly, there's a slightly higher risk of mortality associated with increasing age. Being a man doesn't increase your risk of mortality, you'll be pleased to know, chaps. And actually, Charlson comorbidity score, so this chronic morbidity score, doesn't seem to be associated with an increased risk. It crosses 1, it's non-significant. But what does matter is what causes your small bowel obstruction. So we've used adhesions as a reference point. If you have an abdominal wall hernia, small bowel obstruction caused by an abdominal wall hernia or a cancer, you are more likely to die than the other groups. And certainly the hernia data surprised us, because when you look at it, it's mostly people with groin hernias. Why are people with groin hernias dying? Because that's a day case operation. It's got an elective mortality of less than 0.01%, something like that. So this is quite worrying from our side. Things that are associated with surviving surgery, but we've talked about that, that's selection bias. Having a white count at the point of admission that's above 16, so evidence of sepsis, is associated with increased inpatient mortality. And the other things down here, timing of CT scan doesn't matter, but nutritional risk index, which is that score that I talked to you about at the start, as you cross over from being a low risk group to being a moderate group, the odds of or the hazards of you dying increases. And then once you get to the severe risk category, it jumps quite a bit more. And kidney injury didn't have an effect in this group. So if we're going to simplify it, the things that are associated with getting out of hospital alive are having an operation, that's probably bias. Sepsis control, so antibiotics, and probably nutrition, probably, but we don't know because it's association. Major complications were people who died in hospital, who had an unplanned intensive care admission or were readmitted within 30 days of discharge. Again, if we split this down into things we can and can't change. So again, being older increases your risk, that's kind of a given. None of the other things, Charlson comorbidity didn't really increase your risk at all. And it was only cancer that increased your risk of readmission, well, of major complications, but typically readmission in this group. If we look at things we can change, surgery gives you complications, who'd have known. Your inflammatory status didn't really matter that much in terms of your other major complications. And I just want to draw your attention to this, which is, where's my pointer? So the timing of your CT scan and the association with any of these. If you have a CT scan within 24 hours of admission, you've got a slightly higher risk of a major complication, which is probably because we recognize that you're sick and we want to know what's going on. This is a good example of correlation, not causation. You have a CT in the next day, not much happens. But you have a CT beyond 48 hours, all your risks shoot up. And that is someone where we've not recognized what's going on, or we said, let's just have an X-ray, we won't worry about a CT scan because we know what the diagnosis is, and then we wait for them to fall off the perch, to become acutely unwell, 48 hours later, oh no, better do a CT scan, oh look, everything's gone wrong. That's what I think is going on there. And again, nutrition, that's a massive change. Low risk or no risk, moderate risk, severe risk, so nutrition has a strong association, which is one of the more novel findings of this study. And acute kidney injury just crosses the line of significance to be associated with complications. So again, some pretty pictures because it's easier than the chart. Things that matter are recognizing what's going on early. So we put a picture of a CT scanner because that's the way you know, unless you're going to look inside everyone. Nutrition. Your operations, well, we think doing your operations well might help reduce complications, but I'll leave that with you. And dealing with kidney injury as well is something we need to look at. The next few slides are about variation, because it's like you get a guideline. Do people in this, does anyone here use the guidelines? So there's the Bologna guidelines from the European Society. Does anyone use those? No? There's the I'm getting nods. Can you stick your hands up if anyone does? Ish? Or the American guidelines, the East guidelines. Does anyone use those? Okay. It doesn't matter whether you do or not, because everyone makes it up as they go along anyway, because they say the guideline doesn't really apply to this situation. And as well, in our defence, those are for adhesive small bowel obstruction, and people say, well, it's probably cancer or it's probably a hernia, so those guidelines don't apply. It's a syndrome, which is what we want to look at. This is CT scanning. Who did we CT scan? This is the number of patients each site put into the study. So the biggest site was, I think, 58 after we'd tidied up the data. And this is a proportion of patients who had a CT scan. You can see, and these are the confidence intervals. So if you're lying within these dotted lines, you're probably okay. Your practice is probably in line with everyone else. Red line is the national average, about 80%. We did a survey, which I'm not going to go into too much detail on, but we did a survey of surgeons at all the participating centres to ask what their practice was for various things. And we asked which of these tests are core for your management, which is key to your management of patients, 82% said, I need a CT scan to help me plan my definitive management. And this is pretty much the only time that our data set agrees with what they said in the survey. You can see we've got here some hospitals that are negative outliers. These are hospitals that have a very low scanning rate. We've not gone as far as pairing them up to look at what their outcomes are, because we're trying not to penalise people for being involved. But I would have a suspicion about what's going on there. This is people who had an abdominal X-ray and a CT scan, because what happens is you get a phone. I don't know what happens here, but in the UK we get a phone call from the emergency department. I have someone who I think is obstructed. The SHO takes a phone call. Oh, I'm busy. I want to take out this appendix. Can you just do an X-ray and call me back? Bang. So this is what I think is happening. And then we see them and go, well, they clearly need a CT scan, so let's do that anyway. So they get a double dose of radiation. And if you look between these two slides, you've got these negative outliers here who basically end up, well, they're nowhere because they're not getting scanned as many. You've got some centres that are quite high up here that fall down, and that's because they're only doing single irradiation. So we're getting people who are actually relying on CT as their primary diagnostic imaging. Again, overall, 2/3 of patients got a double dose of radiation. And that's not, that's a pre-CT X-ray as well. Water-soluble gastrography and water-soluble contrast agents. We asked our surgeons how many of you would consider, the evidence base suggests it's got some benefit in adhesive small bowel obstruction. And it's actually in small bowel obstruction is pretty much the only intervention which has trial level of evidence and actually Cochrane reviews. So 80% of people said, yes, I would use it for adhesive small bowel obstruction. 30% used it. So we've got a bit of a mismatch between reality and other things. You've got some centres up here that clearly like to give gastrographin, and you've got a lot of centres that really just aren't using it at all. So again, we've got lots of variation. Now just to talk about nutrition. We split people now into the low risk, moderate risk and high risk group. And when we look at this, this plot, you can see there's no real pattern to it. This is, did they get reviewed by a dietitian and when? Some places we'll ignore those small centres. Some places doing pretty well, and I can tell you, I know which these centres are, and I'll give you a hint in a minute. But most of these, somewhere down here. If you are at high risk of malnutrition, so a group where we're thinking, we might need to intervene, we might need to give you parenteral nutrition, we might need to give you some we might need to get more calories into you somewhere. It's taking us 5 days to get people seen by a dietitian, which in the UK, that is our first barrier to getting parenteral nutrition. So you get seen at we think you're malnourished at the point of admission. Day 5, we get a dietitian to see you. PICC line, 24 hours maybe, unless it's a weekend, in which case 48 hours. And then we'll get you the pharmacy to make up your parenteral nutrition. So you might get it, next Tuesday or something. So that's probably not good enough for the severe risk group. And as you come down, you can see the average time 6 days, 8 days for the low risk group. And you've got to remember this is the baseline status. People will move dynamically between groups because they are starved for longer and will start to lose weight and other things. So this is just based on baseline. And even then, half of patients with severe risk are seen, a third with moderate risk, and 1 in 4 of those with low risk. This is a plot of parenteral nutrition use. Look at these guys, way up there. These two centres are intestinal failure units. So these are centres where their default setting for bowel obstruction is parenteral nutrition on admission. Bang, there is no choice, it just happens. And then you've got centres down here, high volume centres not using it at all. And again, when they wanted to give parenteral nutrition, so they've said they're high risk, 4 days to get parenteral nutrition, 6 days for the moderate risk group, and about the same for the low risk group. So even if we are doing interventions, we talk about moving the line forward for laparotomies, getting people into theatre, getting antibiotics in, getting them to intensive care. If we think about nutritional care, we're probably a long way behind on that. And I'll deal with the evidence base in a minute. Again, supplemental NG feeding. A lot fewer people got this, but 2 weeks in the severe risk group to receive it. 14% of people received it, and it was coming a long way down the line. So these were actually car crash, absolute disaster laparotomies, disaster abdomens who were receiving that. And then ERAS, if you think about ERAS, what do? We get someone out of bed, we start getting them drinking. You might give them the calorie drinks of 46 or Scandi shakes or whatever brand of supplement you want to give. You're going to get them drinking those as soon as you can, so they're absorbing something. Do we do that in emergency surgery? Not really. On the colorectal ward, it's definitely the default. That's what we do. We get you up, we start giving you drinks. But we don't really seem to be doing it. And this is people, again, recovering from gastrointestinal failure who are going to have a physiologically shortened gut because they've got gut wall edema, probably had surgery, so they're going to be nutritionally, on the back foot. Not doing much. Again, not much evidence for this, but I think it reflects the process underneath. Two subgroups I wanted to look at. So the hernia subgroup, I've split it by the number who got an operation and the number who didn't get an operation and just presented their outcomes. If you look at this as a whole, it's actually about 15% mortality, and your issue is coming with your groin hernias and your peristomal hernias particularly, but small numbers. If you don't operate on this group of people, they will be back in hospital within 30 days. So if you don't want to do an operation on someone with a hernia because you think I will break that person, or their abdomen is complex, or whatever, they're going to be back. So you're going to be forced to make a decision at some point that you should start making a plan when you discharge them. So those are the main things to talk about with those. And they are people who've got hernias, but they're people who've got obstructed hernias. It's not a symptomatic incarcerated hernia. These have obstruction. If you look at how long it takes us to get people eating, you can see up here the groin hernias, about 1 in 4 of them hasn't started eating day 7 or 8. Similarly for the midline hernias, the incisional hernias, and your peristomal hernias do even worse. They take ages to get going. So it's not a hernia that happens to have been obstructed. It's one who's got obstruction because of a hernia. And the cancer groups, if we just bluntly look at, because I don't want to spend all day dealing with the many different aspects of this. If you look at, broadly speaking, cancer versus no cancer, and you look at the differences in the demographics, there's no difference in the age of the patients. There's no difference in the comorbidity of the patients, apart from they all have an extra point because they've got cancer. The only thing that matters there, or that seems to matter that we've recorded, is the nutritional state. So half of all cancer patients with obstruction are malnourished at the point you admit them, and you're going to try not to operate on quite a lot of them. So how are we going to deal with that? And you can see, despite the fact that most of them were malnourished, no difference in the rates of parenteral nutrition. And when you look at their outcomes, the cancer group 3 times more likely to die, far less likely to go to HDU or ITU as an unplanned admission. And I think that's because we're looking at them and saying, you've got cancer, you've got probably quite advanced cancer because you've come in and you're obstructed. So you might have T4 disease from your colon, you might have peritoneal disease from your ovarian cancer. And as a result, that's being used as a barrier. How long do these people survive afterwards? If it's 6 months, 12 months, is that the point where we should be encouraging our anaesthetic colleagues to maybe give us a bit of resource to get these people through? Controversial. I've put an arrow next to this one. It's not significant at the 5% level, but it's interesting. The rates of dehiscence are roughly double in this group, small samples, and I think if we sampled it further, that would turn out to be true. So this group clearly has a healing issue. Then finally, if we look down at the rates of deep vein thrombosis, we discussed DVTs this morning, but your rate is about 4 times higher in the cancer group with small bowel obstruction, and that's not just the operated group. So if we wanted to make a difference for the cancer group, I think we need to think about how we deal with the access to level 2 and level 3 care. Is there a reason that we shouldn't be putting people in that as long as we've got parameters set for where we would go? What can we do? I think this is probably more of an issue than has been detected here. What can we do to reduce that? Do we need to change how we do our abdominal wall closure? Can we use binders to reinforce? Are there other things we can do? And then DVTs. I think one of the questions I would like to ask of this data set is, because it's not just the operated group, should everyone who has an emergency admission with cancer really be on extended thromboprophylaxis? Because we stick them in a bed, we let them sit there for 3 or 4 days, we dry them out because they're all obstructed. So they're already hypercoagulable, so we let them get even more coagulable. Should we be thinking about that, and should we be scanning them more routinely? And as I've said, nutrition is one of the big things here. When you look through all the guidelines on small bowel obstruction, you can find reasonable data on the use of gastrographin, pretty good diagnostic data on the use of CT scanning, and there's even data out there about the use of laparoscopic surgery to treat small bowel obstruction. It's cohort data, and I think there's a trial that should be reporting imminently. But that's where the guidelines stop. They say make a diagnosis, do an operation, and that's it. Nutrition is a big thing. We're all gastrointestinal surgeons. We should be concerned with the gastrointestinal health of the patient. Guidelines in the UK, we use the NICE guidelines that say that if someone is unable to eat for 5 days or more, or unlikely to be able to eat for 5 days or more, they should receive parenteral nutrition, because we're expecting them to deteriorate. But based on low-quality evidence, it kind of mirrors what the ASPEN and the ESPEN data say, although they have a little more vagueness to them. So we just want to, this is what one of my colleagues, Tim Wilson, put this idea together about incremental oversight. In the UK, you might have a different surgeon looking after you every day as part of your emergency admission. It's just how things have changed, so you're not owned by one team, so you get this ability to overlook things. So someone might come into hospital, have 3 days of conservative treatment, so nasogastric tube, fluids, catheter. Then on day 3, everyone's bored, we do an operation. And then we wait for them to start getting better. And they have an extended IOS because they've got lots of systemic inflammation. You made a really big cut. The person who did their operation 30 years ago used talc gloves, so it's all really thick adhesive tissue. It's not a very nice operation. And then you get to day 5 or day 7, and you go, we should probably start parenteral nutrition now, shouldn't we? And then you get your PICC line, you get your dietitian, blah, blah, and then eventually 2 days after that, you can start parenteral nutrition. So that's kind of where we start doing this counting. I think many people do in the UK, this count from the day of the operation to say day 5 is day 5 post-operative. But the patient's bowel doesn't know that it's day 5 post-operative. The patient's bowel knows that it's been blocked for several days, and the physiology is respecting that or understands that. So then this is perhaps what we should be doing. We should be starting to count day 0, day 1 at the point of admission, which would bring forward this by several days. So more of your patients would probably need it or potentially benefit from it. But if you talk to the patients, many of them have had symptoms for lots of days before. So a week of decreased appetite and a bit of vomiting isn't uncommon. So actually, their day 0 was well before they came into hospital. If you're actually going to follow the rules and say day 5, you should be starting the plan on day 1 of admission. And so I think this incremental oversight. So we start the count wrong. No one really does maths very well, and we end up not doing it right. These are figures taken from a paper that's going to be in Techniques in Coloproctology shortly. We looked at what was the literature out there on the role of parenteral nutrition in the critically ill surgical patient. So this isn't the big ITU trials are out there, and they predominantly have medical patients in them. They predominantly have, and they looked at things like enteral nutrition compared against enteral nutrition with parenteral nutrition, or enteral nutrition with supracaloric parenteral nutrition. And the problem for our population is that enteral nutrition isn't really an option because their guts aren't working, they have just acute gut dysfunction. And Paul Wishmeyer has published pilot data from the top-up trial, which was supracaloric PN. He noted that actually the surgical patients who got PN seemed to have an exaggerated benefit compared to the medical patients. But it's pilot data, so you shouldn't take that as gospel. But I think that will come out of his main trial. The comparisons that we found in the surgical population, parenteral nutrition versus standard care, whatever that means, in two studies. Parenteral nutrition versus glutamine-enhanced parenteral nutrition, which anyone who's sort of interested in nutrition will know that glutamine-enhanced nutrition was a big thing about 5 years ago. Many of these studies were funded by the drug companies themselves, and so you just have to be a little bit suspicious about the strength of positive results. A couple of studies compared to against enteral nutrition. This is more in the patients who were electives gone bad. Look at hypocaloric parenteral nutrition and branched-chain amino acid supplements. They're all really small trials. Most of them are not very well done in the surgical population, so we can't get an answer from that. We did do a meta-analysis of the data comparing the glutamine-enhanced PN against standard PN, and it looks like there might be a benefit from glutamine enrichment in this group, but we're not really convinced. It's not really compelling data, so the data that we've been supplied by NASBO is what we're going to use to put together a parenteral nutrition trial, which may finish me off. So where's this going forward? NCPOD is one of our sort of arm's length regulatory bodies that picks 2 or 3 topics a year and goes in and pulls out patient notes from across the country and does an in-depth review of case notes. And they are just about to launch their bowel obstruction inquiry, which will get many of the things that we couldn't capture just by saying what happens. They're going to get why it happened. And that's going to be really interesting to look at. We are working up guidelines with the Association of Coloproctology, who I'm tied to, and the Association of Surgeons of Great Britain and Ireland. We're putting together our guidelines, which are going to deal with small bowel obstruction as a syndrome, not small bowel obstruction adhesive, small bowel obstruction hernia. It's going to be about setting those standards for getting a diagnosis and getting the right people into the right place at the right time. And you can bet that it will say CT scan up front, so don't mess around with X-ray. Do a CT scan. If they don't need an operation straight away, if they're adhesive and don't need an operation straight away, gastrographin. And then if that's not through at 6 hours, you should operate the next day. So really bringing it forward, and not allowing the slippage that we see. Oh, I don't want to do that, today's complex. And it will feature a line saying that if you're going beyond 3 days, you're probably going to need 2 consultants to give a justification as to why you shouldn't be doing a laparotomy on this patient today. And it will also feature some very weak guidance on nutrition, which will essentially be, don't let people be malnourished for too long because we don't know the right answer. And obviously, there's primary research coming out of this. I think nutrition's a big question and will have benefit in the emergency laparotomy group. And this issue about stratification of patients, who's going to get better, who's not, how do we put people in the right place at the right time? And there's lots more than that. As you've probably got from this data, it's generated more questions than it's answered. And every time we go back to it, there's another question. So for the cancer group, for example, someone asked me the other day, what is the survival of a patient who's been obstructed due to cancer? How long do they live? What's the health economic benefit of putting them in intensive care? The hernia groups, we're working up some primary research on those as well. If I've stimulated anything in you, please come and have a chat and let's do that. This study wouldn't have been possible without, this is most of the people. It's what 500 people look like. And all of them are going to be credited. They're going to be citable authors on PubMed because that's how this model works. We're grateful to all of those for their support. And thank you very much for your attention.